Good morning to you all. And as previously I have already told that today I will be discussing some important topics on important topic rather, because it is a rather a big topic, and it is a bit recent advances. So it must be known to everyone, those particularly those who are in PDT in hematology, or those who are in PGTs also, and as far as practicable, those who are doing the NEET PG also, they must know this concept, because it will come in their pathology paper. But for them, for the PGTs and the postdoctorals especially, I am making this video rather for postdoctorals. So actually my topic today is the precursor myeloid neoplasm, the recent insight. So the first of all, let me tell about something about the precursor myeloid neoplasm. Actually, what is it? Now, precursor myeloid neoplasm referred to a what is that? That is referred to a hematological disorder that either abnormal proliferation and differentiation of myeloid precursor cell is in the bone marrow. So these are the precursor myeloid neoplasm, and these condition are certain risk factors and for the AML and other related disease. Now the main thing which this I have chosen this topic to you, because it has came frequently in the exam. The WHO classification of tumors of the various organ system provides a unified system of tumor classification, and it is regularly updated to incorporate advancements in our understanding of the disease. Based on the ongoing research conducted by the various researchers and physicians, this classification serves as a globally accepted standard for diagnosing the tumors, conducting research, and registering the cancer case, and monitoring the public health related cancers. Now, the classification and the diagnosis of this disorder have evolved with the integration of newer technologies, okay, like molecular profiling, improving understanding of the genetic and epigenetic alteration, and it has contributed to a more precise and personalized approach to the diagnosis of the prognostic of this neoplasm. And based on the tailored therapeutic approaches, and the precision of the risk assessment has been made possible by the identification of specific genetic variation of the mutation in the genes like DNM1 3TA, then TET2, ASXL1, and furthermore emerging insight into the clonal architecture and clonal evolution. PMN have slight said on the disease progression and the treatment of response. So now I am directly coming to the updated classification. Now in the updated classification of the hemolymphoid tumors, a significant change have occurred with the myeloid neoplasia group. For the first time, the precursor lesion has been incorporated as distinct entities, and this comprise as clonal hematopoiesis with the focus of clonal cytopenias of undetermined significance, which is CCUS, and clonal hematopoiesis of intermediate potential, that is CHIP. So these three are a bit new to one, and there has been a significant one or two questions which have been witnessed in the last 1 or 2 year in the exam of the PDT and PGTs also. Now, with the adjustment of a uniform global definition has been developed, improving the comparability, finding some subsequent investigation. Now, it encompasses, the very important it encompasses various precursor disease states which can over a period of time lead to the development of myeloid malignancy like the MDS or AML, and clonal hematopoiesis is the first desirable stage in this cycle. Now, the clonal hematopoiesis, which is known as the CH, which we have just discussed. This we have discussed. So, it is the first desirable stage in this cycle. Now, clonal hematopoiesis is a term which is used to describe a cell population originating from a number of multipotent stem cell with a selective growth of advantage, but no unexplainable cytopenias. So this the precursor myeloid neoplasm, which I have just discussed right now, which you must know, which is CHIP, ICUS, and CCUS. So the somatic mutation of CHIP is possible, but the ICUS and CCUS is not possible. Cytopenias more prominent in ICUS rather than CHIP and CCUS. Dysplasia is absent in CHIP, ICUS, and CCUS. And increased blast percentage is also negative in all the three. So coming to the selective growth and advantage and but no inexplicable cytopenias, hematological, as I told you, hematological malignancy or like other clonal disease, the CH is more common as the people age. Now, for the identification and acknowledgement of the precursor myeloid neoplasm, significant advancement has already been made, and in the in the recognizing the association with the new entries of the progression of the myeloid malignancy and their link as increased mortality and prominently related to the cardiovascular causes, and the higher risk is generally attributable to the theory that involves abnormal macrophage gene transcription, increased expression of the inflammatory pathways, and the encouragement of the atherogenesis. So this is very important to know. And clonal hematopoiesis of interdeterminant potential of the term used to describe the earliest uh, desirable phases of the formation of the PMN. Now, when a hematopoietic stem cell develops a somatic mutation in a gene-linked myeloid malignancy, the process is known as clonal hematopoiesis, and this mutation leads to the expression of the mutated cell proliferation compared with the other stem cell. And individual with a diagnosed hematological disorder with unexplained cytopenias with the expression characterized by variant allele of the VF of 2% or more. So this is the characteristic feature of the CH. Actually, they are telling, and all the mature blood cells throughout the life and produce HSC. A single lineage of HSC makes a disproportionately large contribution in the population of mature blood cell with the CH, that is clonal hematopoiesis. And interesting to note that it is related to the CH is related to result of straightforward depletion of HC, and in fact older people have more abundant HSC in their bone marrow than the younger people. So this is the more important thing, as you must know. And there are standardized criteria for the CCUS, MDS, and MDS myeloproliferative neoplasm that can be used characteristic of cytopenia, a frequent characteristic of CH. The criteria include absolute neutrophil count of less than 1.8 into 10 to the power 9 per leukopenia, platelet count less than 1.50 into 10 to the power 9 per liter, and for thrombocytopenia and hemoglobin, where values of less than 13 in males and less than 12 are females for anemia. So these are the criteria which are fit for the as we are we have discussed a lot about MDS and myeloproliferative disorder, but it goes same for the CCUS, which is the precursor myeloid neoplasm, the recent which we are discussing the recent insight. Now, the clonal hematopoiesis of intermediate potential, that is CHIP, is a characteristic by the presence of somatic mutation linked to the hematological malignancy in the people without cytopenias or signs with an underlying hematopoietic malignancy. And among the many distinct gene mutation, now what are the gene mutation where you can identify that it is CHIP, is DNM3TA, TET2, AXL1, and occurring ones, and increased more than tenfold risk of developing hematopoietic malignancy is related to the CHIP, which is generally frequent in the aging population. So this is very important to know. And the number of mutations present in the individual affect the likelihood of prognosis of two CHIP. The presence of several driving mutation points to the clonal evolution where blood cells pick up the additional mutation according to the way and become fully malignant cells. So this is very important. And blood counts of the CHIP are within normal range. However, larger blood cell, that is RDW, is linked with the higher risk progression. A red blood cell size variation is quantified by the RDW, which is known as the red cell distribution width. A greater red cell distribution width may indicate ineffective hematopoiesis, the production of blood cells, which is thought to be underlying cause of decline counts and progression to malignant condition. So, if the RDW is increased with this further symptoms, we have to think for a better or alternative diagnosis. So, clonal cytopenias of undetermined significance, that is CCUS, is characteristic by the development of low blood count in one of the more lineages, and in the development of myeloid malignancy, it is being set up by the situation. And comparatively, the CCUS is linked to the presence of clones of inactive blood cell formation. So this is very important. And although results from the low blood cell count or one or more cell lineages, although having low cell count in one or more blood cell lineages and idiopathic cytopenia of undetermined significance, that is ICUS, does not match with the requirement of MDS. So ICUS actually does not match the requirement of MDS, whereas the gene mutation for the both of the thing and the other immunohistochemistry may be separate, that we are not knowing it now. And the various somatic driver mutations undergoes ICUS from CCUS, which is unrelated to the clonal process. Now this distinction of the extension of CCUS is linked to the motility of worse prognosis. Now CHIP has very low probability of developing to myelin malignancy, whereas CCUS significantly increases the risk. The predisposing genetic alteration observed in the CCUS are not present in the idiopathic cytopenia of undetermined significance, that is IDUS, which has which has got the variant illness trajectory. Now, after that, you have understood that what are the precursor myeloid neoplasm, and now we have to think that about what are the management of this myeloid precursor condition. Now, since the precursor myeloid, since the PML is a newly recognized introduced subcategory in the classification of the hematopoietic neoplasm, much prospective studies are still not available on this particular topic. Hence, this entity currently requires management of follow-up of the patient based on the experience and opinion of the experts in this field. And there is ongoing relevant discussion regarding the investigation to be done in incidentally discovered cases of the PML. As this lesion have high prevalence of older population are uncertain to progression of clinical course. So now establishing follow-up clinics of multidisciplinary team of the professionals and counseling monitoring regular system of the PML can be done as started by some institution. Patients should be advised to undergo regular complete blood count every 3 to 8 months, and a bone marrow aspiration. Trephine biopsy of certain cytopenias also keep increasing mortality because of the cardiovascular risk associated with CHIP and CCUS is mined, and such patients should be regulated on the regular basis and managed accordingly. Now, studies are needed to determine the optimal treatment approaches for the use of the targeted therapies and HSC transplantation for the high-risk patient. And in addition, more research need to identify the productive biomarkers and the risk stratification tool that can help to treatment guide for decision for the high-risk individual with the PMLs. Now, these are also very important. Now, this will not only aid in selecting appropriate therapeutic intervention, but also help in monitoring treatment response, and collective efforts across the multiple institutions and countries will be the essential to collect the sufficient data and conduct a large-scale trials. And this will enable to the PML, the development of evidence-based guidelines for the management of high-risk PML, that is precursor malignant lesion, and improve the patient outcome. Now, finally, coming to the recommendation of management for the recommended management for the follow-up of the PMLs. Now, in the case of the ICUS, we have to do a CBC with differential history and physical annually or semi-annually. CCUS we have to conduct with the CBC with differential with 3 to 6 months, history and physical annually and semi-annually. Repeat bone marrow biopsy if the condition is worsening, and we have to also assess the cardiovascular risk. About CHIP, we can say that routine health maintenance, consider again CBC with differential and assess the cardiovascular risk. And moreover, it is crucial to establish a standard reporting system for the PML to facilitate the data and comparison of across the various study, and this will help in identifying the common patterns of trends and ultimately leading to the better understanding of the disease and improved treatment strategies. Now, overall establishment of specific therapeutic intervention for high risk PML, that is precursor myeloid lesion, is an ongoing research area. Further studies and collaboration and the development of evidence further guidance we are ongoing in the research of the further guidance are necessary to optimize the patient of care and improve the patient in the population. So these are the recommended management, the management which I have told you just now about the ICUS or CCUS and CHIP. And lastly, finally, in conclusion, that is the precursor myeloid neoplasm is newly recognized entity in the latest classification of the hematolymphoid neoplasm, and there is a lot of scope in the research in this field, and constant monitoring following with the research education of the counseling of the patients and attending plays a critical role in affecting and managing this condition. So this must be known to each and every person, how to tackle the patient and how to take the history of the patient. That is the main thing. And what are the recommended management and the follow-up, which I just told you. So we have to go in this area. So we can achieve the maximum success rate if the patient is suffering from ICUS, CCUS, and CHIP respectively. Thanks a lot.